was reviewed to me by your own colleagues. About 2 or 3.
Please, it may be possible, but I've not heard anyone like tell me this, or I've not seen anyone do it like with my, or hear like with my ears, so I can't say for sure that that's what has happened or that's what has been happening.
The same thing. You know what happened where one of you went to see a fear from some for this class. So do you think the person will come and tell you that it is? I am telling you. So please be careful.
Yes, please. Yes, please.
If you are part of it, I don't care. If you have any issues, I am saying see me. I'm expecting you to learn. In fact, I'm not expecting you to learn how to be fast on people. So if you have issues, see me. And we know how we can help you. This is what I hate. And you people try to be smart. You get smart thinking that you are cheating. And there's consequence of cheating. So if you have an issue, I'm saying see me. I'm getting these to the extent that somebody told me that you can even group in one place. Okay. So where am I? Have I done DPP-4 inhibitor?
Yes, please.
So I just want to see whether I can come up with a question. I have a small question to ask about the DPP-4 inhibitor.
No, please, your voice is down.
Voice is down. You hear me, don't worry.
Okay, go.
I just want to have some questions. Okay, let's see. In our next lecture, I'll have some questions. Then we know how to discuss. We will discuss those questions. I just want to be adding questions to it. At times, when you read it raw without questions, you won't. But when you read and like you come across question, as you try to answer the questions, then you assess yourself. It will let you know whether what you read is in or is not. Okay, so let's go to let's start. Okay, so we have done metformin. We have done what? Sulfonylurea. We have done what again? We have done what again?
Alpha glucosidase inhibitors.
Alpha glucosidase inhibitors.
And what? That's all.
DPP-4 inhibitors.
DPP-4 inhibitors. Okay, so because we have done DPP-4 inhibitors, let's talk about the incretin mimetics. The incretin mimetics. What is that? If I say incretin mimetics, what is it? Incretin mimetics, what is that? What is incretin mimetics? Incretin mimetics. Are you talking or you are not talking?
These days mimic action of incretin. So they'll basically
I'm listening. So basically, are you gone? So as you said, they will mimic
so
the effect of these, the effect of the incretins, and you know what the incretins that. So the DPP4 inhibitors.
hello.
Hello. Hello.
Hello, Doc.
Yes.
These are saying that they'll mimic incretin mimetics. So they'll sort of cause insulin to be more sensitive to absorb and to cause the absorb like to cause insulin glucose to enter into the cells.
Hey, lad. Come again. You said what? It will mimic, if it's mimicking the effects of incretin, will it increases the insulin sensitivity? Will it, Hillary?
Doc,
You said it will do what?
so it will act like the incretins. So the GLP-1 and then the GIP.
So what it does is that it will mimic the effect of the incretins. Mimic the effect of the incretins. And you know what the incretin does? Incretins will aid in the stimulation of insulin. It's not increasing the sensitivity of insulin, it's aiding the secretion of insulin. So note that. What are some, I don't know whether this is not common in Kumasi, this medication, but it's common. When I came to Accra, it's common. Patients are on this medication. What are some of the examples of these incretin mimetics? What in these mimetics, we said it's mimicking the effect of incretins, mimicking the effect of what? The incretins. And what the incretins does is that the incretins will aid in the secretion of insulin. So these incretin mimetics will bind to and activate, it will activate the glucagon-like peptide receptors. It will bind to and activate the glucagon-like peptide 1 receptors. And when we activate the receptors, GLP receptors, when you activate these receptors, what will happen is that you'll be increasing insulin secretion. Another thing that it does is that it will suppress glucagon secretion. It will suppress glucagon secretion, and it also slow gastric emptying, to slow down gastric emptying. So basically that is the mode of action. The incretin mimetics mimic the effect of the incretin. And what the incretin does is that incretins will aid in the secretion of insulin. So when we are mimicking that, it means that this medication would help. And it does so, it helps in insulin secretion. It does so by activating, it binds to and activates the glucagon-like peptide 1 receptors. Doing this would increase insulin secretion. And I'm saying that it also slows gastric emptying and also suppress glucagon secretions. These are basically the mode of action. Please hold on. Hello. Hello.
Hello, Doc.
Sorry, Dean called me. Okay, so that is that. Have you seen this incretin mimetics before? Those in Accra. Have you seen one before? And what are some of the examples of these incretin mimetics? What are some of the examples? It's not common in Kumasi, but Accra, very common. Who can give me one example of this? The incretin mimetics.
Dr. Takra, Ozempic.
Come again.
Exenatide.
Exenatide. So we have exenatide and what again?
Ozempic.
Liraglutide.
Liraglutide. Liraglutide. liraglutide. So these are incretin mimetics. These are incretin mimetics. I don't know. It's not used, especially in Kumasi, but I've been to Accra and I've seen patients on liraglutide. I've seen them on these medications. When you are learning about, take note of this, when you are learning about these anti-diabetics, you should think about whether the class of that medication reduces weight or not. Because MCQs, we could be asking these. So, why is it excreted? Those things you should know. It's small things. So a small kinetics about these medications, small kinetics. So they have long duration of action. They act longer than endogenous GLP-1. They act longer than endogenous GLP-1. In terms of the weight, what can you tell me in terms of the weight? Does it increases weight? Does it reduces weight? In terms of the weight, who can tell me? In terms of the weight, and it's being used a lot. Those medication is being used a lot. In terms of the weight, I've just given you a clue. In terms of the weight,
Decrease loss.
Weight loss.
it causes what? Weight loss, and it's being used. It's being used a lot for weight loss. For weight loss. So I'm saying that note this, it's these medications, exenatide and liraglutide, they act longer than the endogenous GLP-1. Exenatide is eliminated via renal. These small kinetics, please, in your learning, summarize these things. Exenatide is excreted renally. Who can tell me liraglutide? Which organ is responsible? Exenatide is renal. Who can tell me about liraglutide? Who can tell me? Hey. So MCQs. That is why I'm saying that your is difficult. It's very difficult. Because I'm picking this small thing, can make it a question. Liraglutide, where is it? Exenatide is renal. Liraglutide, where is it? Which organ is responsible? Are you telling me or I should move on?
Is it renal?
No.
So the liver.
Please, if you don't know, don't be saying as if you are asking me. If you tell me the liver and the kidney, it means renal, it means you don't know. So, as at now, the organ responsible is not defined. We don't know any organ which is responsible for clearing this. So the organ is not defined. So take note of this. We don't know why it's excreted because the organ. Exenatide is excreted via the renal. It's a renal clearance. Exenatide is not. Liraglutide is not defined. Exenatide is renal. Clearance is via renal. Liraglutide is not defined. Any of the side effects of incretin mimetics?
Diarrhea.
So gastrointestinal disturbances, there could be nausea and cold. Any other? Any other? Any other?
The appetite is reduced.
Diarrhea.
Hello?
Hello.
Hello.
Sorry, I went. My internet. So I was offline. Okay, so let's continue. So these are some of the basic things that you have to know about incretin mimetics. And note this, normally incretin mimetics will not cause hypoglycemia. Normally, under normal circumstances, incretin mimetics will not cause hypoglycemia. It's not like sulfonylureas can cause it. Incretins does not cause that. Let's move on to another class, which is the glucose transporters. Glucose transporters. The glucose transporters. Let me use the board. So the glucose transporters is something that you have to know. About these glucose transporters. Just want to use the board. So the cell membranes, take note of this. The cell membranes are not permeable. Hello.
Hello.
I'm having this. Hold on, please. Everything else, it's not my leg. Everything else. So when submitted in my mail, the chain number. Okay. Okay, so glucose transporters, and I want to, I'll be, please, can you see the board? Glucose transporters. Can you see the board?
Yes,
No,
Doc.
Yes or no?
I've seen the board. Do you mean the writing?
Writing.
No, bro,
yes.
they're a bit smaller.
Can you see the writings? Can you see? You can't see anything on the white sheet.
I've seen, Doc.
So glucose transporters. So glucose, transporting glucose from the blood to the cells. It's not something automatic. It's not simple that glucose, the cell membranes are permeable to this glucose. You need transporters to push glucose from the cells into different organs. So you need transporters, and you tell them, we say they are glucose transporters. You need these transporters to push glucose into different tissue. The brain is there, even the beta cells, you need transporters to take these glucose into various tissues. So these specialized glucose transporters, they are termed as GLUTs. So glucose transporters, GLUTs. And these GLUTs are responsible for taking glucose into various organs. So you could have different GLUTs. You could have GLUT1, GLUT2, GLUT3, different, and these GLUTs, these transporters, at times, there are certain organs that they will need, these transporters will need a push from insulin. There are certain organs that these transporters will not need the backing of insulin to push them. An organ like the brain, you need glucose transporters to push glucose into the brain. Without the support, we don't need insulin. to aid in that GLUT, to push glucose into the brain. There are certain vital organs that will not require insulin to aid the GLUT, to push insulin to certain areas. Please, do you get me? Glucose transporters will not just get into the cells. It's not easily permeable to glucose is not easily permeable to the cells. It will not just go through a cell membrane into the cells or the tissues. It will not just. You need glucose transporters. And I'm saying that some of these transporters will need the push from insulin. Some of the transporters will not even need insulin. The transporters will take the glucose to those organs without any push from the insulin. So let's say GLUT1. GLUT1 will push insulin. Will push glucose into many cells without insulin backing. So GLUT1 would enable basal non-insulin stimulated glucose uptake into many cells. GLUT1 will enable, that is the transporter, glucose transporter, will enable basal non-insulin stimulated glucose, non-insulin stimulated. So it does not need insulin. Enables basal non-insulin stimulated glucose uptake into many cells. So many cells will be there, and GLUT1 will be taking glucose to them without the backing of what? Insulin, without the push. So we say non-insulin stimulated glucose uptake. That is GLUT1. GLUT2 will transport glucose. GLUT2 will transport glucose into the beta cells. So let me explain here. So when you have the blood, so these are the vessels, and assuming this is the beta cells. So when you have so much glucose in the beta cells, so when you have so much glucose in the blood, these are the beta cells, and this is the vessels containing the blood. So there's hyperglycemia here. What happens is that GLUT2 will be taking glucose from the blood into the beta cells. And what GLUT2 would do is that GLUT2 will do this. This is a prerequisite for glucose sensing. A prerequisite for glucose sensing. Now, GLUT2 will be taking glucose from the blood into the beta cells. And this will sensitize the beta cells that, hey, you have so much glucose. So let's secrete what? Insulin. That is GLUT2. So GLUT2 will be taking glucose into the beta cells. And I'm saying that is a prerequisite for glucose sensing. It would now, the beta cells will sense that there's so much glucose in the blood. So without GLUT2, without GLUT2, giving you that alarm that GLUT2 would make the beta cells know that there's so much glucose in the blood, so we should. Please take note of these GLUTs. This is why we had a medication that is working along this line. So we have GLUT3. So GLUT2 will be alerting the beta cells that we have so much glucose in the blood. So it secretes what? Beta cells. So GLUT3. So GLUT3 I thought somebody wanted to. So GLUT3, we have certain organs like the placenta. It's very important. The placenta, the neurons, the brain neurons. These are very, very important organs. And these important organs, we don't need to wait for insulin to act before these organs get what? Get glucose. So what happens is that GLUT3 would also be taken, will allow non-insulin mediated glucose uptake into the brain and the placenta, into the brain and the placenta. So GLUT3 will be taking these. We'll be taking this. We'll be taking it will enable I told you for the brain does not need insulin to aid the GLUT. So it will be taking glucose, non-insulin mediated glucose, non-insulin mediated glucose uptake into the brain and the placenta, into the brain and the placenta. GLUT4, I don't want to go through all the GLUTs. You could have GLUT9, GLUT10. I don't want to go through all the GLUTs. I'm just touching on the important GLUTs, then we go. So GLUT4 will also allow the peripheral action of insulin. Now we have GLUT4 would allow insulin, the glucose, to get into the muscles and adipose tissues, the muscles and the adipose tissue. And these glucose will need insulin action. So GLUT4 will need insulin for uptake of glucose to the adipose tissue. So the muscles and the adipose tissues will be taking up glucose, and these will be dependent on the insulin action. So GLUT4 will be dependent on insulin action. GLUT3 will not depend on what? The brain and the placenta will not need insulin action before they get what? Before they get glucose. So GLUT3 will be taking glucose into the brain, into the placenta without the aid of what? Insulin. They need a raw, the brain needs it. So the moment glucose gets into the blood, then the raw glucose will get into the brain. So they need the raw glucose into. And when we started these things, we said that we started right now. We said that an proximal convoluted tubule, listen up, at the proximal convoluted tubule, there's reuptake of what? Of these glucose. Reuptake of these glucose at the proximal convoluted tubule. And over there, there's also transported. There's also transported. And these transporters will transport glucose via the tubules. Now, glucose getting into the tubules will be reabsorbed at the proximal convoluted tube back into the system. So they realize that these over there, about 90%, 80% of these glucose, 80% of this glucose will reabsorb back into the system. So now they realize that if they interrupt the glucose transporters at the proximal convoluted tubule, there won't be any reabsorption, and therefore there will be excretion of this glucose via the kidneys to the outside. And what they did was that they decided to interrupt both the sodium and the glucose transporters. So they came out with medications that would interrupt sodium and glucose transporters at the proximal convoluted tubule. And examples of these, who can tell me? Examples of these are what? Medication that would reversibly inhibit sodium glucose co-transporters. Co-transporter 2. Sodium glucose co-transporter 2. They came out with a medication that would interrupt or reversibly inhibit these transporters at proximal convoluted tubule. Examples are what?
Dapagliflozin.
So examples are DAPA, what again?
Empagliflozin.
So DAPA, EMPA, what again?
Canagliflozin.
We have the CANA, we have the EMPA, we have the DAPA. So these are medications, listen, these are medications that, based upon these transporters, they realize that at the proximal convoluted tubule, now there's reabsorption. So if you interrupt with these transporters, it will cause excretion. We have done gout. Let me ask you this. At the proximal convoluted tubule, there's reabsorption of uric acid. Who can tell me one agent that could interrupt with reabsorption? Common agent that would interrupt the reabsorption of uric acid. Who can tell me? For uric acid, give me one agent, common agent that could interrupt, meaning that could cause uricosuric.
Losartan.
Losartan. So losartan can also interrupt the reabsorption of uric acid back into the system. So you have transporters. And what are some of the transporters that can do that? Uric acid transporters. What are some of the transporters? We have forgotten. What are some of the transporters?
And please, we have urate 1, glutenine.
So you have uric one. So please, these are common things. Hey, the notes that you are writing, don't just close it. What you should do is that 30 minutes, you can use 30 minutes after the class. Use about 30 minutes to go through and get it. Don't put it there and wait for last minute. So if it's 30 minutes, just go through it and get it before you close the book. So we have these SGLUT. We have sodium glucose co-transporter 2. So we have these agents that would inhibit these sodium glucose co-transporters. These agents. And these agents are DAPA, EMPA, CANA, and CO. And the general name for these agents are what? Are glyphosate. The general name for these agents are glyphosate. Let's discuss something here. What, in your opinion, now the kidney is going to excrete, because there will be this medication will interrupt the reabsorption. So the kidney is going to excrete the glucose. Tell me, what are some of the limitations in the use of these medication? What are some of the limitations? What are some of the limitations? Can you hear me?
Yes, doc.
For the use of this medication, can you tell me some of the limitations?
Sir, please, your line was breaking. Kindly repeat the question.
I am saying, can you tell me any limitation of the use of these medication?
Patient is at a risk of yeast infections.
So patient is at risk of getting infections. What type of infections? Which the infection would affect which area? You get me?
He's the urinary tract.
So urinary tract. This is one limitation. Any other limitation? Any other limitation? Hurry up.
Hyponatremia.
This is application. Please, this is application. So there are certain things you look at the way that the drug is working and apply. There could be hyponatremia. So I am not, don't bring me to the side effect. The patient is at that is a gap, limitation, at risk of getting UTI. The patient is at risk of getting renal infections. The patient that is at risk of getting renal infection. What again? What again? What again? What again? Oh, You should be able to tell me this. What
Due
again?
to the increased urine excretion.
I'm listening.
So please, I said there can be dehydration due to the increased urine excretion.
You want to push me into the side effects. There could be dehydration, but the limitation, when you talk about, you are exposing the kidney and urinary tract to infection. That is the limitation. Another limitation is that when you have renal impairment, it will be difficult to use this medication. You get it? Class, do you get it?
Yes, sir.
When there's renal impairment, because it's the kidney that would cause the excretion, that has to do the excretion. If there's renal impairment, then you cannot use this medication. So these are two limitations of these. Two limitations. What are some of the side effects of these? General side effects of these. We talked about dehydration. If there's dehydration, what can you say? There's dehydration. Any other side effects? Any other side effect?
Candida infection.
There could be infection, UTI. What again?
Glucosuria.
Come again.
Glucosuria.
There will be glucose in the urine. So please, we have a lot. Because there could be dehydration, there could be thirst. Risk of infection is there. There could be dyslipidemia. Dyslipidemia, need to explain. There could be dyslipidemia. Dyslipidemia, who can explain why this can cause dyslipidemia as a side effect? Dyslipidemia, who can tell me why this drug can cause dyslipidemia? Dyslipidemia. So this drug can cause dyslipidemia as a result, is a compensatory thing as a result of pushing glucose out, more glucose out. When you are pushing more glucose out, it can cause dyslipidemia. The system would have to produce. The system will have to produce glucose, and glucose production will depend on the lipids. So there could be dyslipidemia. So you should know contraindications of these medications, please. These you should know contraindications. So you should avoid when the GFR is less than 60. When the GFR is less than, you cannot use this medication in DK. So you should play around it. Then you have canagliflozin, we have empagliflozin, we have DAPA. But the advantage of this medication is that When a patient comes with heart failure and comes to diabetes, heart failure, then one of the medication that could be considered is this glucose transporters. One of the medication that could be considered when a patient comes with heart failure and diabetes, you can use that. So if a patient comes, you can consider this medication. Even heart failure alone, you can consider this medication. So please, if I ask you, dapagliflozin will come at which strength? Kana will come at which strength? And at which dose? And at which dose? At which dose? At which strength? Can you tell me? And pagliflozin, what will be the dose? You are not talking. EMPA. Kana.
Sir, please, Kana is 100 milligram.
So Kana is 100 milligram. And EMPA is what?
EMPA is 10 milligrams once a day.
Come again.
EMPA is 10 milligrams once a day.
It's 10 milligram once a day. It's 10 milligram once a day. So please note, for Kana, you can go up, can titrate it upwards. For canagliflozin, you can titrate it up to 300 milligram once a day. So please, these are some of the examples and the dose and the side effect of this medication. Do you have any question up to this point? Let's move on to I will try to on my own create a question for you in my next lecture. Test you and see. You are not, I'm not, I wish I could see face to face. Then we have this. We set a question, then we do. We need to add questions to it such that I will know whether you are learning or not. Some of you are just piling the notes. What I'm saying is that I know there's so much on you, and you'll be tired when you come from your workplaces. You'll be tired, I know. But please don't keep the notes. You just read and do a summary. Put down important points. Like we are learning about incretin and incretin mimetics. We put down the points. Make it so you do the summary such that within 10 minutes I can read through incretin mimetics. We just make it, we do a summary of it, important points. Talk about the kinetics. Talk about the mode of action, examples. Let me ask you this. Let me ask you this about incretin mimetics. The liraglutide and exenatide, which route is given at which root? Which root is these incretin mimetics given?
Subcutaneous.
So subcutaneous. So MCQ, we could ask this. What is the ideal route for incretin mimetics? Example, exenatide, ideal route. And make it IM, make it SC. So you could come out with, that is why I'm saying that please make your notes, start early and do a summary of the important things. Do a summary of the important things. Such that if today you want to do, you are called for your exams, you can just be going through these summaries. And just be going through this summaries. So let's move on. So note the side effects, note the contraindications, note examples, how the drugs are given. As a pharmacist, this is our area, how the drugs are given. So let's move on to the next medication, which is tizolidine-dione. Tizolidine-dione. So tizolidine-dione. What is the general name for tizolidine-dione? Or it can also be called what? Tizolidine-diones can also be called what?
Glitazones.
So they are also called glitazones. And for these glitazones, the one which is available is the pioglitazone. Rosiglitazone is no more used because of its cardiac effect. The only available glitazone is pio. And pio has been shown to have significant benefits on microvascular morbidity and mortality. So pioglitazone has been shown to have benefits, significant on microvascular morbidity and mortality, significant benefits. So it's the only glitazones that are used. Rosi is no more used. Who can tell me the mode of action for glitazones? Tizolidine-diones. The mode of action. Who can tell me the mode of action? And it's very important to know this. Who can tell me the mode of action? Class, did I do insulin resistance with you? Pathogenesis of insulin resistance. I did it with you. Class, did I do the insulin resistance? Pathophysiology of insulin resistance.
Yes, sir.
So if I mention resistin, if I mention adiponectin, if I mention TNF, if I mention plasminogen activator inhibitor 1, I mention all these. Okay, so let's talk. What is the mode of action for this class? Oh, what is the mode of action? Class, can you tell me? So the mode of action, they act the glitazone. They act as agonists. They act as agonists. They act as agonists of nuclei. Peroxisome proliferator activated receptor gamma. Peroxisome proliferator activated receptor gamma. So you have P, peroxisome P, proliferator P. We have PP activated A, we have receptor R, and we have the gamma. So we have this peroxisome proliferator activator receptor gamma. This is something very important. This is glitazones are agonists to this. It means that they will stimulate this. They will stimulate these receptors. And when they are stimulating these receptors, then they will have effect. So note this. These receptors are found. They are agonists to these receptors. The PPAR gamma. These receptors are found or expressed in the adipose tissues. Please hold on for me. Somebody's coming. Hello, class. So these receptors are highly expressed. They are mostly expressed in the adipose tissue. Very important. They are expressed in the adipose tissue. I want to link this to the cytokines. I taught you the insulin resistance, pathophysiology of insulin resistance. I taught you this, and I'll be linking this because these receptors, PPAR gamma receptors, are are expressed in the adipose tissue. If I stimulate this, it means I'll be making good use. I'll be making use of the fat deposition because you are stimulating the fat. And this stimulation will be when you are stimulating this PPA, R gamma within the adipose tissues, then you'll be making use of the fat buildup. You're making use of the fat buildup. And another thing that you should know, that is mostly expressed, predominantly expressed in the adipose tissue. It doesn't mean that it can also be expressed in other tissues, other cells. It can also be expressed in the pancreatic, or can also be found in the pancreatic beta cells. Can also be found in macrophages. Can also be found in the vascular endothelium. So macrophages can also be found in vascular endothelium, and the pancreatic beta cells. These PPAR gamma can be found in macrophages, vascular endothelium. So it's not only the adipose tissue, but predominantly or mostly is expressed in adipose tissue. And when you are is an agonist, you are stimulating these, you'll be making use of the adipose tissue. And therefore, who can link the adipose tissue? Who can link this PPAR gamma to the cytokine and tell me the benefit? Who can link it? Who can link it? Link the PPAR to the cytokine and tell me the benefit of the PAAR in terms of the insulin resistance. Who can do that for me? Please, can you hear me? Can you hear me?
Yes. Doc, please, I'm thinking that if they reduce the fat buildup, then there will not be a spillover of those fats, or there will not be like the excessive stretching of the walls of the like adipose tissue to release the adipokines. So it will reduce their secretion. Yeah.
So you are right. And therefore, if I say this medication would increase the sensitivity of insulin, will you side with me? As a result of the stimulation of PPAR gamma, it would increase sensitivity of insulin at the periphery. Can you explain? If I just put this as a question, explain how glitazones would increase sensitivity of insulin at the periphery. Explain this. Can you do that for me?
Hello, Doc. Please repeat the question.
I am saying simple question. If I ask you to explain how glitazones would increase sensitivity of insulin at the periphery. Can you do that? Simple, I'll just put it like this. How would this increase sensitivity of insulin at the periphery? Because one of the benefit is to increase insulin sensitivity. How will it? Please, you get the question.
Yes, please.
So to reduce the amount of resistance at the peripheries. So once the resistance is reduced at the peripheries, there will be increased sensitivity of the peripheral tissues to insulin.
How will it reduce resistance?
So the resistance is coming from the spillover fats from the bad fats from the abdominal tissue, the abdominal fat. Yeah, that is spilling, the stretching of the adipocytes in the abdomen, causing the bad fat from the abdomen to leak to the peripheries.
So I don't lump the two. Don't lump the two. You are making a good point, but don't lump the two. Now you are talking about resistance. Resistance is coming from where? And you are lumping resistance and the spillover of these abdominal fats. So you are combining the two, and be careful about this. In your explanation, I'm expecting you to say this, that the glitazones will reduce the spillover. When you have the spillover of the abdominal fat, these abdominal fat will deposit at the tissues and the liver. In it, they will oppose insulin action. Again, when the abdominal fat are full in the adipose tissues, they are full. They will cause stretching, which is a different thing. There's a spillage, and there's also before spillage there will be stretching, and that will cause release of these adipocytokines. These adipocytokines, which one of them is a resistant, would oppose. So it's coming from those glitazones increasing insulin sensitivity is coming from two things. It's coming from reduction of abdominal fat, because if it's agonist and it's stimulating to burn some of these abdominal fat, you have a spillage to deposit, and for this to oppose, you have that stretching to release cytokines, which resistance is one to also oppose the insulin action. Please, do you get it?
Yes, sir.
Please, the whole class, do you get it?
Yes, please.
Yes,
So,
please.
So that is one. That is something. If I'm asking this simple, how would glitazones increase insulin sensitivity? I'm expecting you to explain this. Solo, do you get it?
No, please, you can come again.
So who can help Solo for me? I'm just going back to what I did with you. So who can help? I know it's not only Solo. Who can help me? Those who understood me.
Hello, Doc.
Hello.
So, in a nutshell, what you're trying to say is that the
Madam, you are gone. Abena,
yes, sir.
Abena, can you come again?
So I'm saying that in a nutshell, what you're saying is that there will be a decrease in the spillover, which would ideally cause insulin resistance. So once that is avoided, you have insulin sensitivity being increased, and also you don't have the cytokines being produced.
I don't know whether you simplify what I said. So simple.
Hello, Doc. I remember from how you explained it to us, you said that whenever there's an accumulation of bad fats at the abdomen, there will be a spillover. But however, before there will be the spill, there will be a stretching, and the stretching will cause the release of cytokines, that's the adiponectins and the resistins. So we are giving the glitazones to reduce the abdominal fats to prevent
Please be careful. Please be careful of the word adiponectin. I said when there's a stretching, cytokines will be released. I didn't talk about the release of what? Did I talk about the release of adiponectin?
No, sir.
Class, did I talk about the release of adiponectin?
No, please.
So please be careful. Go on.
He says the release of cytokines and resistance. I think it's adipocytokines, right? Yes.
We are listening.
Sister, please. So the glucose would decrease the abdominal fat, preventing the occurrence of the spilling.
So it's so simple. Is it Abena? Abena did it so perfectly. About now, you are stimulating the receptors, and the receptors are found in adipose tissue. And it's a agonist, so you'll be stimulating. When you are stimulating it, you are reducing, you are making use of the adipose tissue. You are reducing the amount of fat buildup. And when you are reducing this, it means that when it happens like that, there won't be any buildup such that it will cause stretch, because stretching will cause release of these adipocytokines, which resistance is 1, TNF is also 1, alpha is 1. We talked about plasminogen activator inhibitor 1, which is also 1. This will be released. And I told you adiponectin, I told you that when there's a buildup, adiponectin is found within. When there's a buildup, then you'll be reducing adiponectin levels. I told you this. When you are now reducing the buildup of fat, then you'll be increasing what? You'll be increasing adiponectin. That is why exercise is good. Because when you exercise, you burn. And when you burn, you'll be increasing. You'll be increasing adiponectin levels. Please, do you get it?
Yes, Doc.
So please note this. I am just linking this to for you to know the benefit of using the glitazone. The other benefit of using the glitazone, because these PPA gamma agonists, these glitazones regulates it's regulating these PPAs. These glitazones regulate this. It's regulating that. We have glitazones regulating the fat. Regulating the fat. And if it's regulating the fat, it means that now glitazones, let me say this, glitazones is regulating. It's regulating the fats. If it's regulating the fats, causing reduction. Now, two things. Causing reduction. It means that there won't be any resistant release. If there's reduction in this, to oppose insulin action, there won't be any build-up, spill out, and build-up of fat in the muscles to also oppose insulin action. Because build-up of fat has it's a lipotoxicity to the insulin. So there won't be any spillage to cause deposition. There won't be any resistance. There won't be any resistance to oppose, directly oppose insulin. This is what I am saying. And therefore, we can say that glitazones will reduce, or I can say resistance has anti-inflammatory effect, anti-thrombotic effect. Can I say this? Can I say this? Can I say this? Class, can you hear me?
Yes, sir.
Yes, Doc. Please can hear you.
If I am saying, I need your response for me to know whether to go on or not. If I'm saying that this would prevent inflammation, glitazones will prevent inflammation, will prevent prothrombin, will prevent ABCD, will prevent this. Do you appreciate what I'm saying?
Yes, please.
You appreciate it. But that is, I just want to link this to the benefit of using glitazone. If it's causing reduction, to this abdominal fat, then it will reduce resistance, and that would increase the sensitivity. To reduce resistance, that will increase the sensitivity. It will reduce this plasminogen activator inhibitor 1, which is a prothrombotic. So it will reduce thrombosis. So note this. exams we can ask you this. If I want to go into detail and be pushing you in this line, I can be asking you this. Explain the additional benefit of glitazones in the area of inflammation, in the area of this, the area of this, the area of insulin sensitivity. So you should understand this. Okay, so going back, I say that PPAR is mostly expressed, and glitazones is agonist to this PPAR. So if it does stimulate it, what will be the benefit? What will be the effect? The effect is to lower postprandial glucose. It will lower this. It will also lower free fatty acids. Free fatty acids. So it will lower postprandial glucose. And in addition, it will also lower free fatty acids. It will also enhances insulin sensitivity. It also enhances insulin sensitivity. It also promotes glucose uptake. It promotes glucose uptake and also promotes glucose utilization within the peripheral tissues. It's promoting glucose uptake, promoting utilization in the peripheral tissue. It will also suppress gluconeogenesis. So when I'm saying these things, you should get it. You should be, because I've done the foundation with you. You should get this because it's promoting sensitivity of insulin. If I say it will suppress gluconeogenesis, you should appreciate it. It will suppress free fatty acids concentration. You should appreciate it. So these are some of the effects after stimulating the PPAR gamma receptors. This will be the benefits. In terms of the vasculature, it also has anti-atherogenic effects. And these things, in terms of the vasculature, it has anti-atherogenic effect. And this is all linked to cytokine. All linked to cytokine. So if I'm saying these things, that's why I was trying to say that if it's reducing this, reducing the fat here, it means that we'll be reducing the release of cytokines. If this is reduced, and therefore this plasminogen activator inhibitor 1 will be reduced. Resistance will be reduced. TNF, which will cause inflammation, will be reduced. All this. And another important thing is that you'll be increasing adiponectin. You'll be increasing adiponectin. And you'll be increasing adiponectin. And when you are increasing the adiponectin, we talked about adiponectin. Who can tell me one benefit of adiponectin? Who can tell me one benefit of adiponectin? Class, who can tell me one fact action of adiponectin. Hey, asɛm one function of adiponectin.
Doc, please, we said that it protects the endothelium by preventing the monocytes from attaching to the endothelium. So it prevents atherosclerosis, or like the entire process of atherogenesis from beginning.
So if I say in terms of the vasculature, if I say it has anti-atherogenic effect, do you appreciate it?
Yes, please.
Understand the basis, such that if we are saying A, you know where it's coming from. Because of increased levels of adiponectin, adiponectin will protect the endothelium, and therefore it's protecting the endothelium. Then the issue of atherogenesis will not be seen as a result of increasing it. So please note them. Any question up to this point? Any question up to this point? Okay, so let's talk about the pharmacokinetics of this. And I said that is the only product. Pioglitazone is the only product. Pioglitazone is the only product. So let's now do pioglitazone. Pharmacokinetics. What is pioglitazone metabolite? What is pioglitazone metabolite?
The liver.
It's metabolized extensively in the liver. Metabolized extensively in the liver. Any adverse effect of these? Any adverse effect of this? Pioglitazone. Any adverse effect of pioglitazone?
Please, it causes fluid.
It causes fluid retention, and therefore listed. And therefore, when a patient comes with heart failure, you will not recommend that we should give pioglitazone to the patient. Comes with heart failure and diabetes. You will not recommend pioglitazone. Any other? So note this application, note this. Any other? If it's causing edema, what can you say about the weight?
It will cause weight gain.
So when we are asking you this application, please, it will cause weight gain. It's being associated. This is associated with weight gain because of the edema. Any other? So patient, if a
Hello,
patient,
Doc.
hello,
Please, I want to ask a question in relation to the weight gain aspect. Can it be that because it's also improving insulin sensitivity, that's a reason why it can cause the weight gain?
why not? It could be one of, or partly, we can say partly. It could be one possibility. It could also come from the edema, peripheral edema. Edematous will increase the weight. Any other? Oh, side effects of pioglitazone. Be careful. Oh.
Doc, respiratory infection.
Respiratory what?
Infection.
Respiratory infection. There could be anemia. And what type of anemia? The special type of anemia.
Dilutional anemia.
So there's dilutional anemia. So please, common, and this drug is linked to one side effect of the bone. The bone. There's increased risk of bone fracture when a patient is on pioglitazone. Bone fracture, increasing risk of bone fracture. So please, I am begging you, you don't chew it. I'm not saying chew this, but as you read, common side effects. Common side effects. And at times, when you understand what is happening, you won't chew. If it's causing fluid overload, then weight will be increased. And we are saying there's dilutional anemia because of the edema. Dilutional anemia could also cause upper respiratory infection and also elevate, because it's extensively metabolized in the liver, can also elevate liver transaminase. Liver enzymes can also elevate liver enzymes. How do you give pioglitazone? How do you give pioglitazone? How do you give pioglitazone? Hey, class.
Sir, please, 15 to 30 milligram daily.
How do you initiate it? How do you initiate it? So you give 15 milligram, and the maximum that you can give per day. The maximum that you can give per day is 45. 45. Okay. Okay. I am done with this. There's one class of medication. Maglitinide. One class of medication I didn't talk about, maglitinide. And this class of medication is a class of medication that works like the sulfonylureas. Sulfonylureas, meglitinide. It works like sulfonylurea. And it works in the listing. Sulfonylureas works in the first and the second phase. Meglitinide works in the first phase of insulin secretion. Meglitinide works it doesn't work in the second phase. Meglitinide works in the first phase. That is, but the mode of action of meglitinide is the same as sulfonylureas. But just that sulfonylureas works in both first phase and second phase. Meglitinide works in only the first phase. That is the only difference of this medication. Please, who can tell me, give me one example of meglitinide? It's not even common. Who can give me one example of meglitinide? Hey. One example of meglitinide.
Repaglinide.
Come again.
Natiglinide.
Natiglinide and what?
Repaglinide.
These are the two medications that we have. Two medications that we have. So it's the mode of action is the same as sulfonylureas. But the difference is that this will work in the first phase. Meglitinide will work in the first phase. And sulfonylurea will work first and the second. Is it clear? Is it clear, class?
Yes, please.
So this is what you should know about. I guess it's almost the same, but this is what you should know. This drug is really affected by cytochrome P450 enzyme. Really affected by cytochrome P450 enzyme. And these enzymes are cytochrome 2C8 and cytochrome 3A4. These medications are affected by these enzymes. These enzymes are cytochrome 3A4, cytochrome 2C8. So when you have any medication that will interfere with these enzymes, it will have effect on meglitinide. So when you are giving meglitinide, then you have to know the drug that you are giving. If you are giving omeprazole plus meglitinide, then you should know that cytochrome 3A4 will be affected because the synthesis, the metabolism of meglitinide depends on these cytochrome 3A4 and cytochrome 2C8. So this is that. And this drug can cause hypoglycemia. It can increase weight. So please, I am done with the diabetes. What is left before I start any topic? I will try to get some questions. I wish I see you face to face. Then you do those questions for me as an exam.
Doc, please have a question.
Okay.
Hello, Doc.
I'm listening.
Doc, please. So for metformin, a weight neutral drug.
Metformin. That's what? Come again.
Asking if it will be a weight neutral drug.
You said metformin has what?
No, sir, please. I'm asking if metformin is a weight neutral drug.
Metformin could be used. There's some researches. Metformin could be used to reduce weight. Some researches. So when a patient is obese, you can use metformin. In some researches, some publications says that metformin will have effects, a weight reduction effect. A weight reduction effect. So in obese, you can use it. Is it clear?
Yes, please.
Okay. Okay, any question?
Sir, please, is it based on the same reason? That's why metformin is used in people with PCOS.
PCOS. PCOS comes with complex conditions. We have syndrome X. If I say syndrome X, you understand. Patient with PCOS will come with syndrome X, metabolic. Do you know syndrome X? Come again. Do you know syndrome X, please? So PCOS patient to be coming with hyperlipidemia, diabetes complex. It's a group of conditions. So PCOS patient to be coming with that, which diabetes is one. And therefore, we use the metformin. So PCOS is not one condition. It's not only diabetes. It comes with patient with PCOS will be coming with a lot. Talking about central obesity, talking about dyslipidemia, talking about hypertension. So this patient talking about diabetes. So these PCOS patient to have other conditions in addition to diabetes, and therefore metformin is considered. Is it clear?
Yes, sir. Thank you.
Okay, so if you don't have any question, then let's call it a day. We are done with diabetes. It's left with I'm trying to see whether I can get a question, then we will discuss. Then we move on to a different topic. So good night. Bye.
Good night. Thank you.
No, thank you so much.
Foot ulcer.
Come again.
Foot ulcer.
I'm not done with you concerning photos. Come again. I didn't do photos with you.
Yes,
Yes,
please.
please.
So for type 2, what did I do? For type 2, what did I do? Tell me, ish. For type 2, what did I do? Then you are not talking about.
Please, we did HHS.
So I didn't do.
Yes, please.
Can I do photos now? Can I do the photos now?
Yes, please.
Hey, can I do it now or I should take it to the next week?
The next meeting.
I should take it to the next meeting.
Yes, please.
Okay, then good night.
Thank you so much for your time.
So learn hard, please.
Yes, sir.